Grace, I'm just going to put a mute all, so you and Julie will need to unmute yourselves, okay?
Okay. Welcome, everybody. Thank you for joining us this evening. We're very excited to have you all take the time out and be part of this webinar this evening. And just a little bit of housekeeping this evening. I'm just trying to get my slides. Can you see my slides show?
Yes, we can see. Welcome to our webinar.
Okay, there we are. Just a bit of housekeeping for everybody, just so as we go through, if you can just mute your microphones. I know Sue has put it on mute, auto mute for everybody, but for while Julia is presenting, we just ask that you be on mute. And then if you're going to ask a question or you want to make a comment later, then just unmute yourself. We are quite a large number of participants this evening, so we're not going to have time to introduce ourselves to everybody. So please do in the chat say who you are and where you're from, and maybe your organization or facility that you work in. And then, yes, we always like to say, if you can, put your cameras on. It just helps us feel connected, but we do understand if you can't be. If you are going to ask a question, then at the same time, it would be nice if you could just put your cameras on. If you do have any questions or insights, please do just click on the hands up button that will put your hand up, and then we will look at your question and we will address it during the Q&A at the end. And then, of course, we're not going to be here too long this evening. But just to remember, self-care is important. One of the biggest topics in palliative care. We do encourage that. So if you feel like you need to grab something to drink or move and stretch, please do. And then, as we know, often in webinars, we share experiences and scenarios that we might have encountered. And so we just ask that we respect everybody's privacy if you are sharing in the group. And then, we won't be doing an online survey this evening. Sorry, just to say that is not there. Anyway, without further ado, I'm going to introduce Dr. Julia Ambler, who's going to be presenting to us this evening. So I'm just trying to move my slide, and it doesn't want to move. Oh, there we go. Okay, so we want to send a big welcome to Dr. Julia Ambler. She has been working in pediatric palliative care for the last 20 years. She started her career out in Oxford, UK, where she completed her diploma, and then she's been in Durban since 2009. She co-founded Umduduzi Hospice Care for Children in 2013, where she's the clinical director. Currently, she is the only doctor that is paid for pediatric palliative care in South Africa, working 10 hours a week at Nkosi Albert Luthuli Central Hospital in Durban. She is also a sessional lecturer in the departments of pediatric and family medicine at the Nelson Mandela Medical School at UKZN. So we'd like to welcome Julia. I think for many of us, we know her, and it's always just such an honor to have her come and talk to us with her expertise and her passion that she brings across, and just her caring nature. So Julia, I'm going to say over to you. And yeah, thank you, everybody. I'll be back in a little while.
Thank you so much. I've just sent you a request so that I can share my screen, if that's okay. So thank you for that. There we go. Yeah. Should be coming up now. Let me know if you can see it.
Yes.
Yes, it's
Good.
there.
Okay, so evening everyone, and thank you for having me here. I'm so excited that these courses are taking place and more people are choosing to look at palliative care, both for children as well as for neonates. And now also in the perinatal space, even before children are born. So thank you to PatchSA, and I'm really looking forward to spending the evening with you. So the topic I've been given is always a tricky one: withdrawing and withholding life-sustaining treatment. And I have quite a relaxed presentation style. And while I am talking, I've got my chat open, I might miss something, but certainly Nikki and Sue, it's been a long day. Tracy and Sue, if you see something interesting come up, please feel free to interrupt me. And I really don't mind, having it sort of a bit of discussion. There's a bit of didactic stuff and a case presentation that I'd like to share with you. And we'll take it from there. Right. So let's get going. So what are we talking about when we refer to life-sustaining treatments? And really, it's anything that has the potential to prolong life. So we're looking at experimental therapies that may not even be validated by research yet. We're talking about CPR, mechanical ventilation, intravenous inotropes, antibiotics, renal dialysis, and a big difficult area is clinically assisted nutrition and hydration. And we will touch a little bit on that a bit later. There is no legal, ethical, or moral difference between withdrawing a treatment or not starting an intervention in the first place. And this is, I think, opens up a lot of emotional space for clinicians, for the nurses and the doctors at the bedside, and obviously the other allied health professionals that are involved in the decision making. Some people will say, well, it's easier to, at least we tried, and then we can withdraw it later. And other people will say, well, it's harder to withdraw. Let's not even start, and so that we don't have to withdraw. And ultimately, that's a moot point. If we believe that there is a reason to either withhold or withdraw, there really isn't a difference between the two. And I think we need to recognize early on that it's probably an emotional decision that we are making because of what's easier or harder for us as the individual making the decision. So I want to start off with a case, and this is a very recent case that I saw, and it was a particularly tricky one. And I really want to share it with you because I think it raises quite a lot of the issues that we're talking about. So this was baby AM, newborn, presenting immediately after birth with notable craniofacial anomalies. Now, this child had been in antenatal care, had in fact had scans because mom had polyhydramnios. So there was a suspicion that something could be wrong. But when the scans were done, no one really, the obstetrician and then the fetal medicine specialist, didn't actually see anything. They mentioned that there was a slightly small jaw, but really it came across quite minor. So the parents were reassured, even though they remained somewhat anxious. So when the child was actually born, everyone got quite a big shock. Dad says he noticed the obstetrician's face and as being like, okay, this is not okay. And the baby was blue and not breathing, and the pediatrician had to get involved. And he says, I saw the look between the pediatrician and the nurse, and there was obviously a big problem going on. Anyway, the baby was then whipped off to NICU, intubated, and I'll tell you the rest of the story. But the diagnosis was ultimately made of something called Treacher-Collins syndrome, which in itself is not actually a lethal condition. But it comes along with severe small jaw microdactylia, upper airway obstruction that required prompt ventilatory support. So that was the problem for this particular child. Some of them don't have such severe upper airway obstruction, but this child could not breathe on his own. He had a cleft palate extending through the hard and the soft palate. He had small orbits associated with lower eyelid columbomas. So the eyes were proptopic, so sitting a little bit out. The ears were very malformed and small and significantly abnormal. And within the first sort of few hours of life, the child developed seizures. So the management at the time was immediate airway stabilization with ventilatory support because of this compromised upper airway. The multidisciplinary team was then involved. They got speech therapy, audiology was called, genetics team was called. Obviously, the neonatologist was part of the team, ENT because of the airway, plastic surgery because of all the things that might need to be done in the future, and a neurologist because of the seizures. Comprehensive evaluation was done for feeding difficulties, and an oral gastric tube was passed, and all feeds were then done through the oral gastric tube. And the family did receive genetic counseling. But this is like all now day 5. By now, we're literally only sort of day 5. On day 5, the pediatrician or the neonatologist decided that let's try and extubate and see what happens. The extubation failed. The child could not cope on his own, and recommendation was made that this child will definitely need a tracheostomy, may require percutaneous endoscopic gastrostomy for adequate feeding until all the other surgeries can be done, repairing the palate, repairing the orbits, etc. They also ordered an MRI of the brain. Now, Mom was actually a junior doctor, busy with her community service, and Dad is a salesman, so not medical at all. They have I say strong Christian and isiZulu cultural beliefs. So really very faithful people, churchgoers who trust in the Lord completely, and also in their ancestors and what, being a true Zulu, and what that means to them. So they held a family meeting of the extended families on both sides, and it was decided, given the severity of all of these problems, that they didn't want a tracheostomy, that they didn't want anything more to be done for the child. They felt that it would be not quality of life for the child, and they would rather stop. So now what do we do? We've got a pediatrician who thinks that we should be doing a tracheostomy, Treacher Collins, which is technically not a lethal condition, and parents who don't want the tracheostomy. So where do we stand and how do we make these decisions? So just keep that case in mind, and bear in mind it could be any case that you guys have seen if you've worked in neonates at all. And there are many examples of situations that are tricky where we've now got to decide what is actually right here. How do we make that decision? So what is our guidance? So from the Health Professionals Council of South Africa, we've got a document, booklet 7, on guidelines for withholding and withdrawing of treatment. Now, bizarrely, it is based on a document from the World Medical Association Declaration on Terminal Illness, which was rescinded and archived in October 22. So our guideline, written in 2016, is based on a document that has now been rescinded by the World Medical Association. So that's gone. And they've replaced it with the Declaration of Venice on End of Life and Medical Care. So our document is a little bit outdated, but the principles are the same. So hopefully at some point the Health Professions Council will bring out a new document, maybe, which might be a little bit more helpful than the one we've got. So what does it focus on? All the way through the document, it's worth a read. It's not particularly long. It's certainly not pediatric specific, but there are a few things about kids in there. It focuses on good communication, on the concept of shared decision-making, on autonomy, proxy decision makers and living wills, talks about how good your documentation should be. It refers to resource limitation and how with distributive justice we might withdraw or withhold treatment in certain circumstances because resources are limited. It talks about capacity, the capacity of an individual to make decisions for themselves. So obviously we're only then looking in the adult space, certainly not in the neonatal space. And then it also refers to palliative care, which was quite exciting for me to see that actually the words are in the document that when we are looking at withholding or withdrawing, palliative care should be offered. So a more useful framework for us in PEDS is looking at the Royal College of Pediatrics and Child Health based in the UK. And they've got a brilliant document it's actually 10 years old now. The new one was updated and it's already 10 years old. And it's about making decisions to limit treatment in life-limiting and life-threatening conditions in children. And it's a framework for practice. And it's really worth a read. If you are working with kids, I would thoroughly recommend this particular document. But it describes situations where withdrawal might be ethically possible and specifically looks at how do we spare inappropriate invasive procedures for children that we shouldn't be doing this to them. And I think it's quite helpful because this is a hugely emotionally stressful area for us as healthcare providers, and having a kind of framework to really break it down and come back to basics and think about what is actually going on here. How do I help this child? What is the right thing to do? So I think this is a useful document. But they have 3 categories that specifically talk about when we can withdraw or withhold. So firstly, the first group is where life is limited in quantity. So there's a brainstem death. Doesn't matter what we do, the child's not coming back, so we can withdraw or withhold in that circumstance. Or where the situation is that there is imminent death with physiological deterioration despite treatment. So this might be a child with neonatal seizures. That's just whatever drugs we're throwing at them, the seizures are continuing, the brain is not damaged and we can't stop them. And basically we know that we're not going to get it right and the child is going to die. So we can withhold in that time. Or where there's absolutely no beneficial intervention. So you might have a child with a very severe encephalocele, so the brain is on the outside. There's no real viable brain tissue. The child is breathing, but doesn't matter what we do, we're not really going to be able to save that life. Then there are this second group, which I think is a little bit more gray and requires a lot more conversation, where life is limited in quality, where the burden of treatment outweighs potential benefits, where the burden of the child's underlying condition causing suffering that overcomes potential benefits, or there's just no ability for the child to benefit. And the third category is informed competent refusal of treatment, and that's really for the older child, so out of the scope of today's presentation. So back to basics. I'm sure we're all very familiar with BOCHAP and Childress. We've got the autonomy of the individual matters in ethical decision-making. Babies have no autonomy. It's their parents who make decisions for them. So it's the parents' autonomy that we're looking at. Beneficence, so our need to do good. Non-maleficence, absolutely trying to do no harm. And then lastly, justice. It must be fair for everybody. And particularly in neonatal environment, in the NICU environment, certainly in the state sector, distributive justice comes in a lot, where we have to choose on a daily basis which babies make it into the NICU, which babies we're going to down refer out of the NICU, who we're going to sort of ventilate, who we're not going to ventilate. And those are hard decisions, but literally they are made every day. In the private sector, it's a little different, although the medical aids and the schemes are getting more involved and wanting to know why we're keeping a patient in longer, because there is not an infinite amount of resource out there. So even private sector resources need to be used wisely and justly. But the overarching principle when it comes to children is this concept of best interest. What is in the child's best interest? And this is hard because everyone might have a different view on what that actually looks like. But it is our duty, according to the Children's Act that was promulgated in 2010, that we will always act in the best interest of the child. But best interest doesn't necessarily mean life above everything else. And this is where we have to start reflecting on what we believe as individuals. I believe that there are worse things than death. I think being alive and suffering and going through things that don't actually benefit you are far worse than a peaceful, natural, good death. So really thinking about when we talk about best interest as healthcare providers, we are often only thinking about survival, not necessarily what that survival looks like. And we pat ourselves in the back. We've discharged another child from ICU, and they are coming back years and months later, not to the NICU, not to those clinics, but to the physio, to the OT, to the speech and language therapist, to the pediatrician. Suddenly they've got seizures, and so it goes on. So when we're making these decisions, we really need to take into account not just survival, but what does life potentially look like? And none of us know the future, but we can make educated decisions and have good, robust discussions within our teams to think about these things. So there are three key principles that I want to refer to. So we've got this respect for autonomy. So the parents' autonomy. Children, they're not possessions. So decisions regarding the child impact that, but they're not their possessions. So they don't own them. They can't just decide everything that happens to a child. But at the same time, every decision we make impacts them directly. So and the research shows they do want to be involved in that decision making, and they do not suffer adverse psychological consequences from their involvement. And we'll talk a little bit more about that. But the reality is that most parents expect their role to be protector of their child, advocate for their child. And sometimes they have to step in and protect their child from us because we are so far down a road of our own without taking into account what really is in the best interest of the child. So parents expect to have that kind of responsibility, and we shouldn't be shying away from that. The level and nature of the involvement of the parent should be negotiated in each case. So that's the parent's autonomy. The next concept is best interest, and this comes from Section 28 of our Bill of Rights. And what we need to do here, according to Beauchamp and Childress, is we need to find the highest net benefit among available options that apply to any situation in which a decision has to be made regarding the health of the child. It doesn't have to be best case scenario. It has to be the best option given the available options. So the net benefit has to be where we make our decision. But the document also goes on to say it must take into account physical, emotional, social, cultural, and psychological needs of that child. So it's not purely a decision about life and death, about survival. It is about the whole child. And then the last principle is truth-telling. And I'm not convinced that we are very good at this in healthcare. So often we want to protect parents, we want to protect the child, we want to make it seem better, trying to make everyone feel better, and we might get a little bit stingy with the truth. We'll come back to that. So when it comes to withdrawing or withholding, whose decision is it? And all our guidance says that it must be made by the senior clinician in charge of the patient's care, taking account of the views of the patient or those close to the patient. So in the case of the neonate, we can't take into account the view of the patient, but it really is the view of the parents and the rest of the team. So these decisions shouldn't be made solely by one person saying, I believe this, and that's the end of it. Everyone who's involved in the care of that child should have a say in what's happening. My point here is it's not the parent's decision. In the private sector, sometimes I see that the parents children are ventilated for much longer than they should be because the parents haven't agreed to a withdrawal. And that is a huge thing. You can't ask parents to make a decision about withdrawing. You can have a conversation about it, which is different. The decision is a medical decision. But parents do have a legal and ethical obligation and authority to decide on behalf of the child who can't express themselves. So we must be careful not to burden parents with a decision that really isn't theirs to make. But at the same time, parents want to be involved in the decision making about the treatment limitation. And as I said earlier, they don't suffer adverse consequences from this because it is their job to have these discussions, to protect their child, to get what is best for their child. And then with each family, we talk about it. What are we thinking? Where are we going? And we make a truly shared decision, which we'll talk about in a bit. When it comes to distributive justice, we still have the duty to act in the child's best interest. So sometimes where there are no economic constraints, it can actually lead to worse care and inappropriate care because someone is paying for it. And that is not ethical. We must come back to basics and act in the child's best interest. Just because we can doesn't mean that we should. So just coming back to the Health Professions Council, it is unethical to continue with life-prolonging treatment for the sole purpose of financial gain. Now, I imagine that a lot of doctors in private practice would not be doing it specifically for the money, would not be keeping a child alive for the money. But it doesn't harm them to put a decision off or to delay a communication for longer than necessary because they are getting paid for that time. And I'm so nervous. I don't want to sound like I'm anti-private practice at all. I think everybody's got a role. But I do think that when it comes to us as individuals, we need to really look at what we are doing, how we are practicing, how we are making our decisions, and whether or not there might be any kind of shirking away from harsh realities because it's too difficult or it's too hard. And bearing this in mind that if anyone thinks that we were just doing it for financial gain, there will be trouble. And then also, when patients have exhausted their medical aid schemes, we can't be transferring them off to someone else's care just because they're at the end of their funding. So we really need to think very clearly about what we are doing and if we're doing the right thing, whether we are in state or in private. So let's look at, so we've looked at whose decision is it. So now let's look at how. And this is a quote from the document that I've described earlier, the Royal College of Pediatrics and Child Health. In this extraordinary world of medical miracles, one thing has not changed: the complexity, challenge, and pain of that most difficult of decisions. Is the treatment we are providing no longer in the best interests of the child? There is no technology to help us here, only guidance, discussion, and adequate time and information for truly shared decision-making. Other things we need to take into account before we talk about shared decision-making is goal setting. What are we trying to achieve? And I think this is really useful if you did this with every patient you saw. What is the purpose of my interaction with this patient today? What am I hoping to achieve? What do they need to be achieving out of this interaction today? I think we would provide better healthcare. So are we trying to cure this child? Is this a curable condition where we'll obviously hopefully give comfort measures alongside, but we're going to have a very good outcome? And if that is the case, then we're going to go all out. We're going to do everything. There'll be no withdrawing, no withholding. We'll be doing everything we can to save that life. There might be a place for a trial of intervention. So we think it's not going to work, but it might work. Let's give it a bash. If it doesn't work, we will withdraw, or if the child is not benefiting anymore. Another goal might be to rehabilitate a patient. So if a baby's had neonatal asphyxia, and the damage might be quite severe, but we really don't know how well this child could do and how much brain tissue could recover given the brain's plasticity. So we're going to focus on rehab for this child and get this child as better as they can be. And then there's the other group where we simply focus on comfort and supportive care. We allow a natural death to happen and we plan for that death to be good. But understanding what it is we are hoping to achieve really does put things into perspective when it comes to making the plan and the decisions with the parents. So coming to shared decision-making, and what is it? It's a philosophy and a process whereby the patient, and in our case, the parent or the caregiver, and the professional work in partnership to make decisions about the care. And a few things have to be in place. The health providers come with a specific knowledge set and an evidence base. We are the experts in the prognostication, the understanding the medicine of it. Then there is the parent autonomy that comes in as well, but also it's about their values and their preferences as a family. So to be able to make truly shared decisions with families for their child, one has to understand what matters to them. What are their values? What are their preferences? What would they decide if they were purely autonomous? And the whole thing is really around communication to find out what matters and how do we get medical decisions that align with their values and their goals. So some research that was done in 2020 looking at shared decision-making in the neonatal ICU. The neonatologists that were a part of the study said, yes, we agree, shared decision-making is great. But they admit that they make most of the decisions on their own themselves. They really discuss parental religious or spiritual beliefs, and they view their primary role in consultation as providers of factual information. So this is where the neonatologist stands. I'm giving you the facts, I'm telling you what's happening. I like the idea of shared decision-making, but actually we're going to do it the way I say we're going to do it. The parents, on the other hand, felt that numerical predictions of morbidity and mortality were not as important as spirituality, religious belief, and input from other family members. And I think you can see there is an enormous disconnect in the way that we make decisions where we haven't even asked the family about their spiritual beliefs, about their religious thoughts, about what their families are thinking. We just so focused on numbers and statistics and percentages of who's going to get better and who can possibly survive. And a lot of us harp back on that one child who survived everything. And I get this all the time. But you know, there was a child who had this very same thing. And he's 12 now and he's doing really, really well. And I get that there needs to be hope and positivity from the doctor side. And from the healthcare provider side. But at the same time, we need to be understanding what matters to the parents and the family. So coming back to our three key principles. So these are the parents' values, ideas, concerns, their thoughts, their spiritual and cultural beliefs. Best interest is what is actually best for the child here, what will not harm. And we must bear in mind that we are not obligated at any point to provide treatments that we do not believe will help the child. And again, in the private sector, I find I come up against this all the time. The private hospitals want parents to sign do not resuscitate or do not attempt CPR documentation as if it's the parents' decision. And it's a terrible place to put parents into. I'm not signing that form that says no one will help my child. It doesn't mean they expect you to save the child, but they don't want to be the one to have to put their signature on that piece of paper. And ultimately, if it went to a court of law, if we did not resuscitate or tried CPR on a child that we believed was dying or should be allowed a natural death, that could go to court. But if we can defend ourselves because we are not obligated to provide treatments that we truly do not believe will help the child. And I guess it means that we've got to get comfortable with our decision making and start working in teams rather than on our own, making sure that we do sit down and discuss these cases and look at it from every angle and from everyone's point of view to make sure that we are truly comfortable when we are withdrawing or withholding an intervention. And then lastly, truth telling. We need to make keepable promises, but everything we say must be compassionately honest at every step of the way. And I say compassionately because, you know, for example, I've had another child this week whose parents, the child has a tumor, the parents were told there was going to be a scan. Then the doctor found out more about the tumor from another doctor that had treated them previously and cancelled the scan without telling the parents. And the parents were really upset and let down by that. They felt like, well, that's not fair. You know, we understand if it was the wrong thing to do the scan, but talk to us. Tell us why you have not opted to have the scan on the child. And when they challenged the doctor, he kind of said, well, it wouldn't have helped anyway. And that was truth-telling, but it was not compassionate. And they have trusted this doctor, and he didn't mean it badly. He really didn't. But in that one moment of lack of compassion, he's undone so much good that he's already done in terms of their relationship because they are feeling broken and really hurt by him. Whereas if he was just able to say, to be perfectly honest with you, the risk of doing the scan in this child is not worth it, because it's actually not going to help us. And I'm sorry to say that. If we'd done it compassionately, it would have been a completely different situation. So learning how to tell the truth and be perfectly honest, but with compassion, is a communication skill that we all actually have to learn when we're working with patients in this space. Then we also have to think about our own feelings and motives and core beliefs. And this is all about self-awareness. So I don't know how far all of you are on your self-awareness journey. I'm very good at some things and very poor at others. And it's a constant battle of working towards trying to be my better self. And we should all be on that journey, and just recognizing the trigger points that we have. What are our buttons that get pushed? What are the things that we hold dear, those beliefs that we really, and when a case comes up, it challenges that belief, or that thing that we didn't even realize we were holding so dear. So when we get triggered in a case around ethical decision making, we need to take a step back and have a big breath and go and debrief with someone and really talk it through with someone that we trust, to work out where is that actually coming from. Because it's not fair to put that onto a parent or a child, because we've got issues. And we do it because we're human, but we need to recognize our own humanity and manage it accordingly so that it doesn't end up negatively impacting our patients. So part of this, that first thing, is seeking the parent or the patient's voice. And in this scenario, we're talking specifically around the parent. And some of the questions I will ask when I just sit there is, what scares you the most? And it's incredible the different answers you get to that question. So sometimes I will be told, oh no, this mother's in denial, absolutely in denial. Please come and talk to her. She's just not hearing us. And I'll get there, and it might be a baby with trisomy 18. The mom has been told over and over that the child's life is not going to be long, and she should expect anything, anytime. And I'll ask, what are you most scared of? And incredibly, if a few times over different scenarios, I've had, well, I'm really worried that I don't have a funeral plan and that I'm not going to be able to bury my baby. That is not denial, but it's the way we ask and the kind of seeking to understand what the parent's actually going through. The other question I ask is if I've discovered, and I always take a spiritual history, and hopefully you learned to do that in your course, or you will still learn. But this matters to families. And in a country like South Africa, where almost everyone has some kind of spirituality, whether it be a cultural belief, whether it's a religious belief, we are a glorious nation of, believers in something. So once I've established that they might have some faith or beliefs, what do you pray for? The other question, when you lie in bed at night, what goes through your mind? And I always bring up suffering in cases like this. Do you think your child is suffering? Because when we start bringing in the concept of suffering, there is an onus on relieving that suffering, the onus on us to relieve that suffering, whether the us is the parent or the healthcare providers. Someone needs to be relieving that suffering if there is suffering. So these are kind of things that get me into understanding the parent's voice. Where are they? What are they thinking? And trying to understand that so that we can use it and work with them when we are making these tough decisions. So, for example, I will always say, I know that we're hoping for the miracle. I know you went to church today for a special service dedicated to your baby. And we're all hoping that that's, the miracle's going to come. But we need to think about what happens if it doesn't. So I'm not taking away hope. I'm not stripping them of anything. I'm just opening up a conversation. But because it's done with compassion, because it's done with understanding, I've done with curiosity of what actually matters to you, it can be an open, honest conversation about very difficult things. And parents aren't shocked or surprised by that. They almost expect that they should be involved in these conversations. So listen to hear with empathy, not listening to think about what you're going to say next, which is all of us are very, very good at. Then there's a concept of the zone of parental discretion. What is not permissible in the outer zone, objectively what's in the best interest in the inner zone. And those are the black and white. It's easy. But then there are some other things where the interests that are defined by the parent that we might need to listen to, where we might be able to find an agreement, or where it might be a small and trivial harm. So if the mom says, and understood what you've said, I really think that we should try feeding the baby. And we look at the greater scheme of things and we think, well, actually, this child should be nil per mouth, but maybe a few drops here and there to make mom feel like more like a mom. It's not really going to harm the baby. So we can allow that. So this is what we call the zone of parental discretion, where parents get to have a say. But there are those things that are clearly in the best interest and those things that we cannot allow. So we're not going to hurt a baby because a parent wants us to do that. And sometimes we, like, I don't know if some of you will remember the case of Charlie Gard, a baby that was born in the UK, and his parents wanted to fly him to the States for all sorts of treatment. And the doctors went to court to stop them, so that believing that that would not be okay for the baby, that would be harmful to the baby. And so that was not permissible for those doctors. But I do think these two other gray zones are really important, and we need to be more flexible and really listen to what the parents are saying, and maybe delaying treatments or giving pass outs, or I'm trying to think of examples, times where we can allow for something a little bit different that wasn't quite in our plan because the baby's not going to be harmed, or the parent is going to be enormously benefited. So we might do an additional unnecessary test on a baby to help the parents with closure rather than, and it doesn't harm the baby too much. The hurt can be managed with procedural pain management. So trying to listen to parents and make sure that where there are options to give parents power and to help them feel empowered, to give them some choice and some control is an option. So once you've got their opinion and their voice and you've understood them, this is where we can now share our voice humbly as part of shared decision making. We gently share the facts, we include the uncertainty, and we allow time to sit with pain and fear. And then we share our ideas about the way forward. So it might be, I think we've come to that point where your child is really not doing very well, and despite everything we have done, we might actually be harming him more than we're helping him now by continuing injections and needles and putting him through pain that isn't going to benefit him. But we can do that when we've understood what they are thinking. You said earlier you didn't want your baby to suffer. Well, I think what we're doing now is making him suffer. But it's a much better conversation because it's informed, and I can actually share my thoughts about the way forward because I understand where the parents are coming from, and I'm being humble about it. These are basic communication skills that we should all seek to perfect and just get better and better at every day. And the thing is with shared decision making is we can't just say, well, here's a smorgasbord of options. Here's your menu. Which do you pick? That's not how medicine works. We are the experts. We should share our opinion. We could do A, B, C, or D. At this point in time, I really think that with everything you've told me, with everything I understand about your child's condition, that B is probably the best. What do you think? So you're still giving an opinion. You're still sharing with parents what they should be possibly doing, but you're leaving it open for conversation and to seek understanding from each other. And of course, don't forget palliative care. There is going to be conflict sometimes. It can be within the medical team. It can be within the family, between the medical team and the family and the parent and the nursing team, the subspecialists arguing with each other professions coming in. And we just have to try and be sensitive to others' thoughts and feelings And a very poor solution is it's my way or the highway. And I work in an environment where there are those individuals who only believe it's my way or the highway, and that really doesn't work. But we do have to challenge sort of the hierarchies that exist to develop mutual trust and try and work together when these situations happen. So preventing or resolving conflict in withdrawal situations, we need to self-reflect and be aware. All those buttons that get pushed, we need to be aware of them. Empathy, openness, honesty, humility to develop a trusting relationship with a family. Shared decision making works so well because you've got the family's understanding, you've listened, you've heard, and then you are involving them without actually burdening them. Helping the whole team to make decisions. There are units where a multidisciplinary team is the cardiologist, cardiothoracic surgeon, neonatologist, neurologist. They're all doctors. For me, that is not a multidisciplinary team. It needs to be anyone who's laid hands on that child, the nurses involved, the physios, OTs, anybody else who's involved in the care of that child. The key is to listen more than we speak and think about the parental zone of discretion. When we're feeling our buttons being pushed by a parent, what is actually allowable? Is there space here to make a different decision or to delay a decision because something's going to really benefit the parent? And we do come in with a lot of judgment for these parents. Like if mom doesn't want to sleep at the hospital, can't believe she doesn't want to sleep at the hospital. It's her child, doesn't she know how sick her child is? There may be other very good reasons that she's not sleeping at the hospital. So really kind of thinking about what does the parent have the right to decide. If all else fails, consider external mediation and second opinions, and the legal route is always the last route. So coming back to baby M, my very challenging situation, the parents were adamant they wanted no more testing to be done. The neonatologist said, well, I'm not really happy to make that decision. I think we need an MRI scan of the brain to help us prognosticate. And then the parent said, and then we're not doing anything else. And the neonatologist said, well, let's just see what happens with the MRI scan. Eventually, the MRI scan came back, and it wasn't that bad, but there was some cerebral atrophy there, and which means it wasn't 100% normal either. So now we've got a baby who looks grossly abnormal, that has going to need surgery around the eyes to help with the bone structure there. Is going to need some sort of surgery on the ears to make them look more normal. We don't know what the vision of the baby is like, and we certainly, the hearing on the may or may not be there. The child's got a grossly undersized jaw, which is causing upper airway obstruction that cannot be managed without a tracheostomy. And the parents eventually say, well, fine, do the MRI. We did the MRI. The parents say, okay, now we think it's time to stop. And I'd been called earlier in the week, and I'd had conversations with both the parents, and I really believed this was a good decision they were making, not because they didn't care about this baby, not because they didn't want an abnormal baby, because they genuinely believe that putting this baby through surgeries to repair the cleft, to the tracheostomy, to the jaw, to the orbits, to the ears, is going to significantly impact this child's quality of life negatively. And the child could die at any point in the way with all the surgeries and the anesthetics. And they just couldn't face doing that to their baby. So they'd made a decision for themselves. The neonatologist still felt she would be at legal risk if someone came and said, why didn't you save the baby if we were to withdraw the ventilator? And so therefore she withdrew from the case, which upset the parents because they had developed a relationship with her and they trusted her. But anyway, she didn't feel like she could actually do it herself, so she withdrew. And we then, with the parents' consent, with the, as I say, not consent, but knowledge and understanding, we gave the baby small doses of morphine and midazolam to ensure that there was no distress when we withdrew the tube. We withdrew the tube, the baby was exceptionally comfortable and actually died 6 hours later. in the parent's arms, surrounded by family. So for me, that was a good outcome, but there was a lot of challenge on the way to coming to this decision and what is actually in this child's best interest. Because if these parents had said, no, I want the tracheostomy, I want you to do this, we would have gone down that road. So the pediatrician was saying, well, I don't feel comfortable withdrawing on a baby that could survive if we did this procedure. So I hope I've asked more questions than I've actually answered, because I think that is the point of these ethical discussions, is none of us have all the answers, and we have to recognize that we don't know. And prognostically speaking, especially in the neonatal space, it's very uncertain. We have to do that, what we call that parallel planning. What if the baby had survived without the trachea and without the tube? We had to say to the parents, your baby might not die tonight. Your baby might actually breathe. So we need to be aware that this is not, and I think at the end they didn't know what they were praying for, whether the baby should rest peacefully or if they could take the baby home without the tube. But the bottom line is there is no real right or wrong. It's about the ability to take everything into account. The clinical condition is only one part of the story. All the kind of what ifs, the thinking through scenarios, and then of course getting the parents' perspective and opinion and values and preferences, so that when we come to making that shared decision, it is a truly good one and hopefully in everybody's best interest, but particularly the baby. So I've come to the end of my presentation. There is my cell phone number and email address if anyone does ever want to make contact. Perhaps we can just open it up to the floor. Any questions or comments? Can I stop sharing? And if people want to pop their cameras on, if they feel like it. I know that was a bit of a marathon.
It was really interesting. It didn't feel like a marathon, Julia.
You're biased.
No, I just think a lot of what you've just discussed is what we actually covered in the last module. So I think you've just reinforced all the learning that took place, and I think it's so nice to just hear it from, the expert in a real practical situation. So I think you've answered a lot of questions there.
Yeah. Great. Nikki, I see you put in the chat there about I wish. I'm just trying to go back to I hope. And I think those are useful phrases. I wish it was different. I wish we could do more. You're not saying, I'm afraid there's nothing more we can do for your child. You're being a real human and expressing a real concern and what matters to you as well. And I do think that lands very well with parents. I'm just looking at the chat.
I don't think there were any other questions. Julia, I have a question.
Sure.
When were you asked as Umduduzi to get involved in this this case? Because we often say, when should it be integrated? And we always say from diagnosis or recognition. But it's just nice to always hear on the ground when palliative care is being introduced.
Yeah. So in this particular case, it was quite early. The child was born it was literally, I think, day 5, where the parents were coming to, it was really getting to loggerheads with the neonatologist who didn't want to listen to the parents. So it was quite early, and then the child died on day 8. So it was a short time span. And certainly what we've seen at Albert Lutuli Hospital, the neonatal, since they started referring to us, they're actually our biggest referrer. I would say almost probably nearly a half of our referrals come from the neonatal unit. And that is because they're recognizing the need for this kind of support for parents and for the discussions around uncertainty. And I think that's so important, that sometimes we think things are looking so bad and actually it turns out quite well and the baby goes home. I saw a child today that Nikki met soon after birth in 2023, and the child is now, we can discharge her from palliative care, but there was a time when we thought this child would surely die. So I think there is this real need to hold parents in that space of uncertainty, but have those hard conversations so that when there are decisions to be made, we are ready and we know which way to go. Oh,
Thank you.
I'm just scrolling in the chat. I don't know.
Privilege has got a question.
Yes.
Sorry, if the parents insisted on the trachea, what was going to happen?
Then they would have had a trachea. Yeah. And I think that is also reasonable, because quality of life of a child is quite subjective, and Treacher Collins is not specifically necessarily lethal in its own right. So it's not like this was a dying child. This was a child who couldn't look after their own airway. So a tracheostomy would have been a reasonable option if the parents had wanted it and were prepared to go through that and put their child through that. And there are cases of Treacher Collins that have done really well. And I think the key here for me is bringing in, so that the pediatrician wanted to focus on the fact that Treacher Collins is not a lethal condition, but we were talking about a child who had other things going on. So it's trying to bring it all together and let the parents voice those real fears. And, so they would have gone ahead, and hopefully we would have stayed involved and made sure that good decisions were made along the way. And if at any point we felt that the child was suffering, or we were acting in not in the child's best interest, we would have to kind of try and steer it a different direction. I don't know if that helps.
Thanks, Julia. Julia, another
Diana
question.
wants to ask about team discussions.
What?
Just like to chat about team discussions, please.
Okay. What do we need to chat about team discussions?
Possibly how you go about it. I'm not sure if you can
clarify. So, wait. So I think, does the person who asked the question want to unmute and explain a bit further?
Tatiana? Yeah.
I think, the difficulties are around trying to, and it depends where you are and who you are. So we've been at Albert Lutuli a long, long time, and we have really worked very hard to get the healthcare team to trust us, to have input into these conversations, and make sure that people are invited to these meetings to talk about it. So it's not been easy, because not a lot of doctors, and I want to talk about doctors particularly, are open to having team discussions and don't really want to be criticized and don't really need other people's opinions in their opinion. So it is about trying to, if possible, try and invite the the conversation and ask to be part of it, especially I think with nursing staff that are on the floor with those parents, with their child day in and day out, seeing the changes, seeing the suffering, getting a completely different perspective than the doctor who's coming and going all the time. So I think that, as nurses, we should be, trying to advocate for the patient as well, and saying, please, can I be part of the conversation? Can I hear what's happening? And I know with hierarchy, it's not always possible, but I do think that a lot can be done to kind of move towards that, where naturally speaking, we are starting to involve the whole team in these conversations. So I'm not sure where that question was particularly going.
Can you hear me now?
Yes, excellent.
Oh,
thank you.
Hallelujah. Sorry. I was battling to unmute. Thank you, Julia. That was amazing. So my biggest issue, so I work in private practice at a hospital that does a lot of cardiac surgery. And yeah, I sometimes do feel like we just, I say we, but some of the doctors just see the child as a heart and forget about everything else. And it's really just been, I mean, I was involved in a case just before I came over, and I wasn't the primary neurologist, but it was a child with retin A toxicity. So multiple problems. And had had the surgery, but now was sitting with bilateral pleural effusions, drains in each side. Yeah, it was really just terrible to see. And then had developed a septicemia, so was being given platelets and blood and everything else. And I struggle in my entirety, if I can say that, to kind of, when do I pass like an opinion that is just so important? Because I just think that sometimes and I don't think this is financial. I just think that it probably is more hierarchical. I stand to be corrected, but it worries me that we're not doing enough. We don't know when enough is. Maybe that's what I need to say.
So are you coming from a nursing perspective then, or a...
No, I'm coming from a doctor's perspective. And the one thing that we are doing right is that our multidisciplinary meetings are inclusive of our therapists and our nursing staff, in most cases where I'm involved. Yeah.
Okay, so from a doctor's perspective, it is hard because I work with a lot of people who don't like to be challenged, not specifically in our NICU, but just generally. And these conversations are inherently quite challenging because I'm sharing a thought about what I think is potentially in the best interests. And I guess one of the things that really helped me is working on a graph of respect versus concern. So if you can picture, on this axis, you've got respect for your colleague, and on this axis, you've got concern for the patient. And when you are so concerned about the patient and not thinking about how your colleague and their role, you might come across, I have recently come across as quite aggressive and angry and upset because I believe this is right and therefore you are wrong. And in that process of disrespecting my colleague, it doesn't matter how much I care about the patient, my opinion isn't going to be heard. So I think finding the balance of having enough respect for your colleague. I know that you really invested in this patient. I know that you've spent long and hard trying to get things right. Can I share my concern? I'm really worried that we might be doing too much to this child. Would you mind sitting down so we can talk about it? And that has really helped me to kind of make sure that I keep my my respect for my colleague, which sometimes runs very thin and very short, but focusing on what I think is in the best interest of the child at the same time. So it is finding that balance, but I think it is literally stepping back and going, are we doing what's right? And I think there is a role for every second or third day, maybe even every day, going, are we doing the right thing? Are we doing the right thing? And just having a check-in. Are we still on the same page? Are we doing the right thing? And seeing where the dissenting voices come. And there might be one nurse who's heard a mom's pleas and cries after hours that has a different opinion. Yeah, not easy to do.
Thanks.
Julie and
I think
Nicole,
there was a question from Philippa.
Yeah.
Penfold, she says, I'm in private practice and my hardest discussions would be easier if resources were more limited. Parents want to push and do everything and stay in NICU forever. And we can't really say no bed because there's always a bed. Baby eventually dies, but in a horrible way. Any thoughts?
Very strong thoughts, Philip. Very, very strong thoughts. And I think it comes back to that question, asking ourselves every day, are we doing the right thing? Are we doing the right thing? And if there's any inkling that we're not doing the right thing, then that's the conversation we have to have. And it's not about resources. It's about sharing a concern with the parents. So checking in and saying to the parents, how do you think we're doing? And seeing where they are. Often parents can see that things are really, really bad, but they need it to come from you. You need to share that concern. And until we say it, they're not even going to go there because they've got their faith systems, they've got other beliefs. If the doctor's happy to carry on, we're happy to carry on. And I worked with a family where the child was in NICU for a year. and really shouldn't have been, had numerous attempts of trying to die and was always stopped. And eventually, after a year, I managed to convince the pediatricians that it was really beyond time. And that family, they were not benefited by that. The mom has never gone back to work. That constant uncertainty for a full year, when in actual fact, we always knew the prognosis was poor. And the only reason that the doctors did do that, it wasn't about the money, was really because the mom, this was her only son, and she'd had 9 miscarriages. So they just couldn't bring themselves to do it. But I think that we need to look at, why are we making decisions? Why are we deferring decisions? Why are we not having these conversations? Because it doesn't have to be about the money. It's really about what we believe is in the child's best interest. But that information has to be shared on a background of true understanding of where the parents are coming from and what the actual issues are and what they believe and where their faith system, because everyone's still praying for the miracle. And we get that. We don't disagree with that. We just know what we can share from a purely medical point of view. And sometimes it takes a few stabs at the conversation to get them to shift. But I always find that also using a model like Spikes, or where it forces you to, in the breaking of bad news, having these conversations, to ask the parents what they already understand. Where are you now? What are you thinking? That makes a difference, because then when you know what they're thinking, your next role is to try and move them and shift them a little bit. And without knowing that, if you just come in and say the same thing that you said yesterday, things are really bad, Mom, it doesn't shift them. There's no movement there. But getting them to say it out loud, really, where are we now? What is happening now? Helps to move them in their emotional and psychological space into a deeper place of acceptance of something worse, and going on and going on and going on. So I hope that helps a bit.
And then Giovanni asked, she said, incredible talk, thank you. And are you available to consult and assist in private if needed?
Depends where. But
Giovanni?
Yes.
You're on mute, Giovanni.
Yeah, hi Julia. that was a lovely talk. I'm out in Umhlanga, actually.
Oh yeah.
So
yeah, no, we can come to Umhlanga.
yeah, I just recently actually had a case before I started this course. So timely as it would be, I booked the course before this case happened, and then the case happened, and it was unexpected and quite sad, really. But it's nice to have that frame of reference now to work with. As you go through this course, you think back through everything you've done every single day and start seeing, okay, here's where I could have done something differently. Okay, this we did well, but we could do something different. And yeah, you're right. I think with everybody who speaks about private as well, it's so much better in the government system, where you can have these multidisciplinary teams that work together, and you can have the input of other doctors, other specialists, other ancillary services. And in private, you're working alone, and your only input is often from the nursing staff, which really makes a big difference. I mean, you really go by what they say. But yeah, that's a lovely talk, but nice to know.
Give me a call. No
Right.
problem. So, I see that Nicole Bell has got a question here. I have a question particularly as it relates to care in the public sector, where despite the ideal of shared decision-making, lots of decisions regarding ICU admissions, way extubation are very much consultant-led. How do we handle circumstances where parents really do not agree with the decision to extubate? Ethically so tricky. Is there a role for ethics committees? When and how do we get to that point? I also worry about the impact of parents' grief of having care being withdrawn despite their strong disagreement. Yeah, it is really hard, and I think it also comes back to why they're not wanting us to withdraw. What has actually been said, and I think we just have to keep going back to, what do the parents actually understand? You know, what have they heard? Because sometimes we say something. So I was with a patient the other day, and the dad said, and I spoke about the tumor in her chest, and the dad said, but it's not a tumor in her chest, it's just fluid. And I'm like, well, that's what he's heard. Okay, so I see now that what he's heard and what the doctor said were two different things. And I think this is we've got to go back to what have the parents actually understood about the conversation and the condition and why we would even want to withdraw. You know, because obviously withdrawal is hard for us as well. You know, it's not something we look forward to. So I think kind of for me, that's why are they withdrawing? And I think there is room for trying to give a bit of time for these families to come to terms. But we do have to do it. We can't sort of keep a child in ICU and allow other children to die because they can't get in. So I think this is a highly skilled communication session that needs to happen, where we really are kind of coming in and finding out what is the parent afraid of, because no parent wants to lose their child, but what have they actually understood? What are they hoping for? What does the alternative look like to them? And I think it's those conversations that really need to happen. And then there is a role for ethics committees, but often that it's quite academic and it doesn't actually help the parent. I think we've just got to keep coming back to what the parent is seeing and hearing and understanding and feeling, and working with them where they are in time and space. Okay.
There's a comment from Kim. I've had the opposite situation. It's my doctors that want to push and operate and almost keep things from the mom, when we as allied feel strongly that enough is enough.
Yeah. Really so hard. And in this case that I've just presented, Ron, it was the doctors that just couldn't face the idea of letting a child die of upper airway obstruction for a condition that's not technically lethal. And they struggled with it so much so that she had to withdraw from the case. And I get that it's you know, it's hard, and if you just didn't have to ask for consent and you could just push things through, and that obviously is very unethical and can land us in a lot of trouble. So yeah, I think it's our role as well, people in the know, to try and gently help others to come to see how it can be different. As Giovanni was saying, you know, I'll look back and you realize how we might have done things differently and might have done them better. So speaking up wherever we can and wherever we can feel, and do it with compassion, because I think this is the other thing, is that it's not because they're necessarily horrible people, it's they're doing what they think is right as well. And that's sometimes very hard when you're coming up against someone else. Okay, any other thoughts, comments? I see Marilisa says too many resources. So Marilisa is yeah, in the Middle East where there are lots of resources. Good. Well, thanks everyone. I've really enjoyed being part of this, and I'm just so excited to see all of you here and to see so many names I also recognize and miss dearly.
Yeah. And thank you, Julia. I really think this was a phenomenal discussion, and I think just one we're always wanting to hear more about. I think it's a topic that, you know, as we said, that brings its challenges, but it's always so great to hear from an expert and just to hear. And I think just to find out how important communication really is at the end of the day. It just goes back to basic communication skills. And then that compassion that we've got to know what's in the best interests